Nutrition. Today's video we are going to talk about nutrition in surgery. So normal biochemistry, each and every medical student has passed through a biochemical or a biochemistry class, and this is what you know. This is a normal response of the body when you are starved. So within 12 hours of fasting, the insulin level and the glucagon level obviously will alter. Where you have the insulin level will go down and the glucagon level will go up. You'll have the process of gluconeolysis, where you convert the glycogen to glucose. Also the Cori cycle. If it's greater than 24 hours, you have the conversion of substances such as amino acids or fats into glucose in the liver. And if it's 48 to 72 hours, you have lipolysis and adaptive ketogenesis. This is normal physiology and biochemistry. So in terms of trauma or sepsis, what will happen? Obviously, we'll have contractory hormones increasing. This include epinephrine, this include glucagon, among others. Also there will be increased energy requirement, that is 15 to 25 more. There will be increased nitrogen requirement. There will be increased insulin resistance or stress induced hyperglycemia. This is normal. If you have stress, which hormone will be produced? Cortisol. If you have cortisol, cortisol will promote increased blood glucose. So you have preferential oxidation of lipids, increased gluconeogenesis and protein catabolism, loss of adaptive ketogenesis, fluid retention, and hypobilirubinemia. So these are just the energy requirements you are going to go through. All patients admitted to hospital should be screened for malnutrition and have their nutrition state assessed. So we can roughly divide this nutrition assessment into three, where you have the clinical aspect, where you have the body weight and the anthropometric, and where you have the lab techniques. So in the clinical, you have a focused history taking and a physical examination. In the body weight and anthropometry, you have a BMI, usually less than 18.5, usually indicate impaired nutritional impairment, and below 15 it usually corresponds to high hospital mortality. You can also add anthropometric measures, that is skin fold thickness, the mark, that is mid-arm circumference. In the lab techniques, you have albumin less than 30 grams usually indicate more of malnutrition, but it is not a specific tool. Others like lymphocyte count and skin testing, which show defective immune system, but still not a specific tool for malnutrition. But these things can help you determine if the patient is malnourished or not. So later we are going to look at a tool that is called the MASS tool, that is done to every patient to assess their nutritional assessment. So the next thing is just like a summary of what we talked in the first slide, where we categorize nutrition assessment into three. We say there's clinical aspect, then we say there's body weight and anthropometric, and then later we say there is lab. So this is kind of a summary of everything together. So in the dietary, what are you going to ask this patient? Are they anorexic? Are they nausea? Are they vomiting, diarrhea, malaise? Also the history of weight loss. It is significant to know that this weight loss must be unintentional weight loss. So if they have 10% of their weight loss in 6 months and 5% of their weight loss in 1 month, it's an indicative of significant weight loss. In the physical examination, what are you going to look? You're going to look if this patient emaciated. How do they look? Are they apathetic? So you also assess the body fats, you also assess protein store, you also assess metabolic stress. So in metabolic stress, there are several things. Here is where now you assess the lab, as we said in the previous slide, where you can measure albumin, you can measure WBC count. However, note that these measures are not specific for nutrition, but they are just things that will help you assess the nutrition state of the patient. The last thing that we are going to talk about is the physiological function. So if this patient has been having wounds, do these wounds repair? If you have done wound healing, you really know that nutrition is very essential for the healing of wounds. Do they heal wounds well? Is it fatigability, grip, respiratory function, muscle test? So this is just a rough idea on how you can do nutritional tests. Thank you for watching. So who gets this nutritional support? So any person has had past medical history of undernutrition or malnutrition, involuntary weight loss as we have talked about in the previous slides, blood loss greater than 500 ml, BMI less than 18.5 as we have talked about, serum albumin of less than 3 or transferrin greater than 200 as we talked about, failure to thrive, severe burns, trauma, sepsis, pancreatic, NL per oral for greater than 7 days. So let's talk about the routes of administration. So after you have done your assessment, obviously using the MASS tool and the things you have talked in the previous slides, you now make a decision to initiate specialized nutrition support. The first thing that you ask yourself, is my patient's GIT functioning? Is it a yes or a no? Whenever you have a functioning GIT, you must use it. I've said you must use it. So if it's yes, you use enteral nutrition, GI function. If no, now you use parenteral. The next question you ask yourself, is this parenteral nutrition that I'm giving my patient, is it short term or long term? Then if it's short term, you use peripheral parenteral nutrition. If it is long term, you use central parenteral nutrition. If my GIT comes back, I go back to my enteral feeding. Kindly note the importance of this slide is if your GI is functioning, kindly use it. So in enteral feeding, there's hierarchy of feeding. So what do I mean by hierarchy of feeding? So for example, if you have a patient and is unable to eat sufficient nutrients, you give this, or you start with this patient with oral nutritional supplements. If you have another patient who is unable to take these sufficient calories orally, or they slow dysfunctional swallowing, now you go to the NG tube, that is the nasogastric tube feeding. Then if the esophagus is blocked or it is dysfunctional, then you go to gastrostomy tube feeding. If the stomach is still inaccessible and or you have outflow obstruction, now you can use the duodenum. I hope you have understood that hierarchy. So you don't just come, you meet any patient and then you just give them a duodenostomy. No, you have to assess the GI of this patient. So if this patient is able to feed, there is no abnormalities in the GI, then you start at the superior hierarchy. If this patient is unable to swallow, for example, or is unable to take these oral supplements, then you give NG tube. I hope you have understand. So this is kind of a summary. If you have the mode of feeding, it's either sip or tube. So in tube is where you have fine bore, you have NG tube. So you can read this for more information. So what are the advantages of enteral feeding? As we have stated before, if your GI is functioning, kindly use it. And we have several methods that we have talked about the hierarchy. So what are the advantages? Why we keep saying use the GI? Number one, it preserves the gut integrity, it decreases the likelihood of bacteria translocation, it preserves the immunological function of the gut, it increases the compliance with intake, the cost is less, and it can be accurately monitored. So what are the complications of enteral feeding? We start obviously with the tube. So if you're using tube, for example, the tube can be malpositioned. If you use an NG tube, you can malposition the tube, you can displace, there can be blockage or leakage, erosion of the skin mucosa. The next we go to GI. It can either have diarrhea, bloating, nausea, vomiting, abdominal cramps, aspiration, and constipation. So another complication is solute overload, where you have diarrhea, dehydration, electrolyte imbalance, where you have hypokalemia, hypomagnesemia, hypocalcemia. So this in short is, I can describe it as, so when you give this patient, for example, who has been malnourished food, normal physiology states that when glucose is absorbed by the intestine, which hormone is produced? Insulin is produced. So when insulin is produced, its function is to take this glucose into the cells. So insulin does not only take glucose into cells, but also takes electrolytes like kalemia, that is potassium, resulting to hypokalemia, hypomagnesemia, etc. I hope you have understood that concept. Next, here we said aspiration. So in this aspiration, it can be caused due to either overloading, or when you place the patient in a supine position, or if the patient is unconscious, for example in surgery. So parenteral nutrition is defined as the infusion of nutrients a nutrient hypersmolar solution containing carbohydrates, fats, and other essential nutrients through an intravenous route, meaning a vein, delivered via intravenous catheter. So these components of this protein, fats, carbohydrates, and what are the components? So in proteins we have amino acids, in carbohydrates we have dextrose, in fats we have lipid emulsion. So, and also we have electrolytes such as potassium, sodium, chlorides, vitamin, and minerals. So we have two types of parental nutrition, where we have peripheral parental nutrition and total parental nutrition. So just a typical difference between these two is that the peripheral parental nutrition is delivered, number one, via the peripheral vein, number two, it's for shorter periods, while the total parental nutrition is delivered via the central vein and it is for longer periods. So like these are some of the points where we have it provides calories for less than 2 weeks, low dextrose concentration, that is 5 to 10%. The amino acid concentration, it's concentrated with lipid 20%. The osmolarity is obviously less and it's delivered into a peripheral vein. Total parental nutrition is high dextrose, that is 50 to 70%. Amino acid concentration is 8.5 to 10%. Osmolarity is high, that is greater than 1000. Catheter use such as silicone and rubber. That's just some minor details. So just this another table just describe difference between central parental nutrition and peripheral parental nutrition, or just central line and peripheral. So site you use a central line, mostly is usually subclavian line. Peripheral use a peripheral line. Osmolarity, we said for the central one is usually higher, greater than 2000. For the peripheral one is less than 1000. Volume, minimal volume, peripheral, large volume. As we talked about central line, usually for long period of time. Peripheral lines short period, less than 2 weeks. Calories delivered in central lines are high calories, while in peripheral lines are minimal. These are some of the complications which we are going to talk about, but kindly note, when you give high osmolarity to in peripheral vein, you'll have thrombophlebitis. So advantages of enteral feeding, advantages of parenteral feeding provides nutrients when you have 2 to 3 feet of small intestine that has remained, or when the GI is intolerant of feeds. So especially of indication of parenteral nutrition are maybe after major surgery, when you have bowel obstruction, when you have enterocutaneous fistula, massive bowel resection, malnourished patient undergoing chemotherapy, nil parolo of for greater than 5, or for any. So refeeding syndrome. Refeeding syndrome is where you have potentially fatal, which it can be defined, condition which can be defined by severe electrolyte and fluid shift as a result of rapid reintroduction of nutrition after a period of inadequate intake. So for example, you had your patient who was malnourished or at a risk of undernutrition, and later reintroduced feed maybe at a higher rate compared to the normal. This patient will have severe electrolyte and fluid shift. Next, you're going to do is pathophysiology. You cannot understand something unless you know its pathophysiology, especially in medicine. So what happens in refeeding symptoms? This patient was malnourished or had a risk of undernutrition, and now you have given the patient food, that is. So what happens? Obviously, there will be rise of insulin. What will happen with insulin? Insulin is produced in order to return blood glucose back into the cells. Not only will insulin act on glucose, but it also increases cellular uptake of potassium, it also phosphate and magnesium. So starvation, because this patient was already a starved patient, this patient will have thiamine and mineral deficiency, and it is exacerbated upon an anabolic process. Anabolic process, now we have given the patient food. So here we'll have renal reabsorption of sodium increase. This is because of insulin. So now you'll have fluid retention. From this now we can know the clinical manifestation and the complication. So the clinical manifestation, obviously we'll have electrolyte deficiency. As we said, we have electrolyte and fluid shifts. Already you have known why we have those. So You'll have electrolyte deficiency, that is hypophosphatemia. You'll have hypokalemia and hypomagnesemia, and also thiamine deficiency and volume overload. So the medical complication you have grouped it according to the systems. So cardiovascular, you can have heart failure, arrhythmia, peripheral edema. Respiratory, you have impaired respiratory function leading to dyspnea and respiratory failure. GI, you'll have constipation, diarrhea, and elevated LFTs. The muscular system, you have impaired contractility, myalgia, tetanus, and rhabdomyolysis. Neurological, you have tremor, paresthesia, delirium, and seizures. So the next, we are going to talk about, so what are the risk factors and how do we manage this? The risk factors obviously is reduced intake, where you have a prolonged fasting or low energy. So this includes marasmus, or where you have your surgical patient who has dysphagia, especially in stroke patients, esophageal cancer, etc., or a patient with high stress patient and who is unfed for greater than 7 days, patient with anorexic, depression, or chronic alcohol use. So this is reduced intake. These are the factors. So reduced absorption, I malabsorptive syndrome, so IBD, chronic pancreatitis, short gut syndrome, increased metabolic demands, for example, post-op patient, oncology patient, and lowered physiological reserve, so in elderly patient and controlled DM, among others. So how do you prevent and manage? Number one is for you to identify the risk. So the patient's identification of high risk patients, that is greater than 2, they have more than 2 of the following: whether they have a BMI of less than 18.5, an intentional list, as we talked about, that is less than greater than 10%, or in the past 3 to 6 months. Also, you can include an intentional weight loss of greater than 5% in 1 month, little or no nutrition intake for greater than 5 days, history of alcohol misuse, drug history, i.e. Insulin, chemotherapy, antacids, diuretics, nutritional replacement commencement after correction of electrolyte abnormalities, vitamin supplementation. So this is how you treat, sorry. So you treat by uniplenish nutrition commencement after. So you don't give the nutritional replacement before you give electrolyte correction. So you first correct the electrolyte and then later give the nutritional supplements. Then you also vitamin supplementation started with refeeding and continued for at least 10 days. The NICE guidelines, refeeding is started at no more than 50% of estimated energy requirements. The rate can be increased if no refeeding problem detected clinically or biochemically. So next, we are going to talk about refeeding. Overfeeding, overfeeding is usually resort to overestimation of the caloric needs. So clinical, if you give a patient increased food, this means that your body has to take that glucose and metabolize it. So in normal biochemistry, where you have glucose, we need oxygen to metabolize it, and the product of that metabolism will give us carbon dioxide. I said, for you to understand anything, you have to understand the pathophysiology. So how will the patient present clinically? Increased oxygen consumption, increased carbon dioxide production, suppressed leukocyte function, increased infectious risk, obviously because of the leukocyte function. You'll have hypoglycemia because obviously you have overestimated your caloric needs, hepatic dysfunction from fatty infiltration, respiratory acidosis from what we have just talked about, from increased CO2 production, difficulty weaning from the ventilator, obviously because this patient has respiratory problems such as respiratory acidosis. So short bowel syndrome. Short bowel syndrome is where you have massive resection of the short bowel. So symptoms are severe if you have greater than 75% of the bowel resected, if the ileocecal valve is removed, if the remaining of the bowel is already deceased, or it is impaired with impaired absorption. So here in this short bowel syndrome, you already have a decreased intestinal surface area. If you have decreased intestinal surface area, this means that you have decreased intestinal transit time, which means you have decreased intestinal absorption time. In addition to that, you will also have the 3 of the following: gastric acid hypersecretion, dilactic acidosis, nephrolithiasis. So the treatment of this short bowel syndrome is: number one, post-op, you adequate replacement of IV fluids, electrolytes with zinc and H2 receptor antagonists, obviously to prevent the gastric acid hypersecretion. Bowel adaptation period: if the stool output is less than 1000 ml per day, you can start enteral feeding. You also administer glutamine and medium chain TAGs. These ones maintain the mucosal healing. In long term, you give small and frequent oral feed as started in intact colon, obvious, and you give diet-rich complex carbohydrates are given. So if the small bowel that had been resected was the terminal ileum, you obviously have to give vitamin B12.